Last month, the WHO issued a global health emergency over monkeypox. Closer to home, Illinois, New York, and California have all issued similar emergencies. So how concerned should we be? Will preventative measures like lockdowns return? Joining us to talk about this issue is Harvey Risch, Emeritus Professor of Epidemiology at Yale University. Dr. Risch is an expert on infectious and chronic diseases, and he has published multiple studies on early treatment of COVID-19. Dr. Risch received his MD from the University of California, San Diego, and his PhD in biomathematics from the University of Chicago. Welcome to the show, Dr. Risch.
Pleasure to be with you.
Let's start by talking about what monkeypox is. Is it similar to COVID, or is it a completely different type of virus?
Monkeypox is similar to smallpox, not similar to COVID. However, it's a much milder, less aggressive form of an infection than smallpox is, although there's still some overlap. And that, in fact, is why smallpox vaccines even have some benefit against monkeypox.
Okay, and currently there's about 6,300 recorded cases of monkeypox just in the United States alone recorded by the CDC. So let's start by talking about how infectious this is. How easily can it spread? And do you think the rate of spread, the rate of reproduction is faster or slower than COVID?
Oh, its reproductive rate is definitely slower than COVID. It takes a much larger amount of monkeypox virus to spread it. It's not spread through casual contact. It's not spread through the air generally. The CDC webpage lists whole details about forms and mechanisms of spread, and it says it takes prolonged face-to-face contact in order to spread it, which means that casual conversation is not enough. Basically, touch. So contact with infected materials, either directly from an infected person, from the rashes, pimples that they get, or clothing, sheets, and things like that. A substantial contact from that also is enough to spread it. But that also means that most people outside of the affected community will be very unlikely to get it.
Let's go over the symptoms one more time. You said rashes and pimples. Do infected persons always show symptoms?
Generally, yes, at some point. It could also be like any other viral illness of fever, headache, muscle aches, things like that. It's not a respiratory disease, so you don't see lung involvement, but you still see kind of the general discomforts associated with viral illnesses.
Mm-hmm. Does monkeypox, smallpox typically target certain demographics, Dr. Risch?
In this case, the monkeypox is almost entirely limited to the males who have sex with males community, we refer to as MSM community. It's not in the general community, it's in the part of the community that has multiple sexual partners, that those partners increase the probability of coming into contact with someone who's carrying it, which also leads to a mechanism of prevention, which is the temporary suspension of close physical contact with large numbers of people.
Okay. So in your view, Dr. Risch, how likely can this become a global pandemic?
Well, it is spreading globally, but 98% of it is in the community that I identified. Mm-hmm. And that means that it's not of a general risk to people as a whole. Just like COVID was really only a risk for elderly people or people with high-risk comorbidities like obesity, diabetes, cardiovascular disease, chronic kidney disease, and so on. For everybody else, it was a discomfort, could be really unpleasant, but not life-threatening for most people. And the same is true here. For monkeypox, it's a very restricted demographic that is at risk, and the rest of the population is essentially not.
It's interesting how there already is purportedly a vaccine for monkeypox, if I understand correctly. Is this something that you think is going to be mandatory for the general population?
No, there's no reason that. First of all, I believe it's a smallpox vaccine that has overlap effectiveness with monkeypox. Secondly, most people of older ages were vaccinated with smallpox, at least in North America. So there's no point in that. And thirdly, there are medications that, like TPOXX, that treat monkeypox pretty effectively. And there's 2 or 3 others as well. And these things can be obtained in the US from doctors applying to the CDC, who has a supply of it. And so monkeypox is treatable and should be treated in people who get it. It's not life-threatening. It can be disfiguring. It can be very uncomfortable, depending on where the pox lesions are, whether the rashes are. If they're on sensitive tissues, it can be very uncomfortable.
Okay. Once a person is infected, is there early treatment for monkeypox?
So yes, TPOXX is a medication that doctors can apply to the CDC to receive to give to their patients, and it works fairly well as far as I understand.
From the early reports that have come in, there's been health centers across LA, for example, that have been overwhelmed by people either seeking treatment or wanting some sort of vaccine or preventative care. Do you think we'll ever see a scenario in which our healthcare system becomes once more overwhelmed by this endemic or pandemic?
No, I think it's unlikely to get out in any major way into the any different demographics than the one that I said. I think
Okay.
this is it's not that infective that it's likely to spread. It hasn't spread widely in Africa, where it's endemic, and I think the same is going to be true here.
All right. Now, let's talk about COVID-19. You've done a number of studies on the pandemic that we've seen over the last 2 years. Let's start by talking about the government response to COVID-19 and your research. In the research that you've done, have you concluded that the response to COVID-19, i.e. lockdowns, were necessary and productive?
Well, at the very beginning of the pandemic, when we didn't know anything about COVID-19, then there was reason to think that a temporary lockdown of short duration would just give us some breathing room to figure more out about it. However, and that lockdown, there's evidence that that initial lockdown in March or so, March, April of 2020, did reduce the spread of the illness a little bit. The problem is that lockdowns only prolong the inevitable. They don't actually solve anything. And therefore, all the lockdowns subsequent to that did nothing. They just, I don't think they even reduced the spread because they were not sufficiently hermetically sealed, like some of the Chinese lockdowns have been, to do enough that would have prolonged. In Australia, it was tighter and it prolonged the inevitable. And what happened in Australia, we see, is that after the lockdowns opened, the population was a sponge and just sponged up all of the available SARS-CoV-2 infections that spread very widely in spite of vaccination programs there. And what we've seen, and so lockdowns basically are a useless policy and should never have been done. The damage done to the rest of society grossly overweighs what supposed benefits the lockdown might have provided. The other things like masking and distancing have negligible evidence of benefit for reducing spread. The vaccines that we've seen now, we've had more than a year and a half of experience with them, show that for the first 2 weeks after each jab, they increase the risk of getting infected from 2 weeks to some time period, 16 weeks, 12 weeks, 8 weeks, 6 weeks, depending upon which dose. They reduce risk of transmission. And then after that, the transmission risks go to zero, and then it becomes negative. It increases the risk of getting COVID after longer time periods. So the vaccines have this time course that is complicated, but in the long term has negative benefit for suppressing spread of the infection, is only increasing the spread now. And now that we're at a long time period where most people have been double or triple vaccinated, and that was completed months and months in the past, they're at very great increased risk of getting COVID and spreading COVID. And we've seen that where triple vaccinated people that, very widely have gotten COVID and maybe even twice. And that's because vaccines are interfering now with the ability to fight off the COVID infection.
Can you explain, just in layman terms, how the vaccine interferes with your body's ability to fight COVID?
So after the period of benefit of the vaccines wanes, what happens is the newer strains of the virus have a different spike protein on them which is the antigen, the part that the immune system responds to. And vaccinated people, these mRNA genetic vaccines, when they're presented with the new virus, they make a lot of antibodies to the old strains that they were vaccinated against. Those antibodies bind to the virus, but they don't neutralize it. They bind to parts of the spike protein, but not well enough to neutralize the spike protein. And it allows the spike protein to get into cells, even though, and in fact, it blocks some of the places on the spike protein where the immune system is responding to the new virus, but not well enough to neutralize it. And so in effect, the old vaccine is inhibiting the immune system from being effective at making antibodies to the new viral strains. And that's what we understand to be the mechanism of why people who were vaccinated but too long in the past are actually increased risk of getting the infection. Now, that's a question of transmission. The government interest is solely in reducing the spread of the infection. And now we can see that the vaccines have lost their ability to do that and made it actually worse, if anything. The second question is whether the vaccines are reducing the mortality, the seriousness of the infection. For a while, that was true, but like the spread, that has also been reduced with longer amounts of time. So after 6 months past the vaccines, people are now at increased risk of serious outcomes from the COVID infection compared to unvaccinated people. There's evidence for this coming out in multiple places. And so people who have been vaccinated long in the past and are getting COVID need to pay attention to their comorbidities, obesity, diabetes, cardiovascular disease, same as before. Such people need to have early treatment available. We've seen Paxlovid failure multiple times now. President Biden, Tony Fauci, Stephen Colbert, other well-known people have gotten Paxlovid rebound. The rebound appears to be more prevalent in people who've been multiple vaccinated than in unvaccinated people. However, there are plenty of other drugs to treat COVID early on. Ivermectin, hydroxychloroquine, and other drugs are workable drugs that should have been used early in the pandemic, and they are still usable for people who get COVID, who are at high risk, vaccinated or not. These drugs are available and should be used. People who use them now, doctors who are treating COVID patients tell me that ivermectin, hydroxychloroquine usually treat the symptoms in a day to 2 days, that people recover mostly within a very short time frame, whereas Paxlovid takes 5 days and has a very good chance of recurrence after a week for another 5 days and prolongs these infections to 3 to 4 weeks.
But Dr. Risch, we know that viruses mutate, and so yes, you're right. We do need to update vaccines if they are effective at all. But that argument, can't that be applied to any virus, or is that COVID specific? That certain vaccines only have a limited window of effectiveness, as you would describe them?
Well, no, viruses have a very wide range of different properties, and the COVID virus is a very rapidly mutating virus, and that's why it's a challenge to make vaccines, that by the time you've made a vaccine, it's out of date, and because they mutate so fast. In fact, the SARS-CoV-2 virus mutates in each person that gets it. Each person makes thousands of mutant strains by the time they become infective. And some of these, spread in the population, and that's why there's 10,000 or more different strains of this virus from the first year or so that it was out, and they keep getting more and more strains. And part of it is because vaccinated people don't completely suppress the virus, so the people still make the virus and they still make mutants and they get out. It's very difficult to make vaccines for viruses that mutate quickly, like the COVID virus. Other viruses that are slow mutating, like measles, for example, is great to have a vaccine for, because and polio and so on, because they don't mutate very quickly, and so vaccinated people suppress the virus, and that's the end of it.
Okay. Well, I'd like to discuss policies in response to monkeypox. So far, we haven't seen lockdowns or mask measures or anything like that yet. Do you think those could come?
I would hope not. I think it would be destructive and foolish and against scientific evidence to do things like that. Those measures were counterproductive in the first place in COVID, and they would be doubly so in monkeypox.
Okay, well, you're a mathematician by trade as well. You've conducted mathematical models on COVID-19's spread and the effectiveness of the lockdowns. Tell me about the models that the governments have used and how you would rate those.
Modeling today is a very unsatisfying method of predicting the future of pandemics. And the reason for that is that all models have assumptions. One assumes values of certain parameters in models, and those parameter values need to be exquisitely accurate. The slightest error in those can lead to dramatic errors in prediction going forward from those models. For example, you can think of the butterfly effect in weather prediction, that a butterfly flapping its wings will affect the prediction of weather 4 days or 5 days or whatever later. The same thing applies to these kinds of mathematical models, that errors in assumptions about the models lead to dramatically wrong modeling, as we saw coming out of the UK at the beginning of the pandemic, predicting tens of millions of deaths when there were hundreds or thousands. In reality, these models have been dramatically wrong, and reliance cannot be placed on them. So as much as modeling can be an academic interest, it has essentially no bearing on pandemic public health policies.
Do you think that we should, or not we, but organizations like the CBDC should construct simulations to prepare for the future or the next pandemic, whatever that might be? I'll give you an example. This is sort of a off-the-cuff, tongue-in-cheek example, but this did happen in a video game, World of Warcraft, a few years ago. It's a multiplayer online game where players control an avatar and they, do various things in this open world environment. And what happened was there was a bug in the game where if you come too close to a computer player or a computer character, you would get this virus that would basically deteriorate your health, and your character would die in a matter of minutes. The bug then persisted throughout the game for several hours, I believe, or close to half a day. And if you come close to a contact with another player who has this virus, the same thing would happen to you. Basically, you would contract it, and your character would die. And so what you saw was a mass exodus of cities, these populated towns in the game, and the virus would transmit because players would go from one area to another very quickly. And the point I'm making is the CBDC actually contacted Blizzard, the studio behind the game, and asked for data and wanted to research player interaction and player responses to a fictitious virus or pandemic. But I think that, to my knowledge, that's probably the closest we got to a simulated virtual world environment of a pandemic. How would you construct a simulation?
Well, there are mathematical models for simple epidemics, and that's what my PhD was on.
Yeah.
And it shows, all those models in their simplest form show that the case numbers peak, they go up, they peak, and they go back down as population immunity increases over time. And either the infection will be so infectious that everybody in the population ultimately gets it, or it'll be lesser infectious and only a fraction will get it and it'll die out. That's the simplest model. Now, more complicated models allow the infectivity of the virus to change, new people to come into the population, people to leave the population, people not to mix uniformly, but to have pockets like cities where they mix uniformly, but they're spread out over a larger population. Mm-hmm. There are all sorts of things. And once you introduce all of these kinds of refinements, the models get much more complicated, and you see all sorts of different kinds of behaviors, including the fact of the epidemics subsiding in cities, for example, but then some new person infected from somewhere else comes in and reinfects the city, and it reaches a new equilibrium where a few more people are infected before it stabilizes. So you have all these different mathematical oddities of these models, but they don't necessarily reflect reality. The computer game strikes me as reflecting more about the fear of the players than the infectivity of the organism, that people choose behaviors based on fear, not necessarily on accurate scientific evidence.
Interesting. So speaking of accurate scientific evidence, then what does the scientific evidence suggest we do going forward, and not just finish off on COVID? What should the governments or government agencies do if they were to accurately or use accurate scientific evidence to base their policies on? We're not completely out of the pandemic yet. There are still strains floating around. So what should be the appropriate response going forward?
The appropriate response going forward is to release the suppression of ivermectin and hydroxychloroquine, to take out all the fraudulent government suppression information like the FDA's website against hydroxychloroquine, and to let doctors prescribe what they think is in the patient's best interest, and not for the government to practice medicine. That when doctors can do that, these outpatient treatments work very well. For example, Dr. Marble in the myfree.doctor telemedicine group has treated now over 275,000 COVID patients and 6 deaths out of that. It's a remarkable record over the whole United States. His whole group of physicians all over the US doing telemedicine have treated close to 300,000 patients and 6 deaths out of all of that with hydroxychloroquine and ivermectin.
Okay.
And that, these things work. All of the propaganda that's gone on to suppress them, to pave the way for vaccines and expensive patent medications, has been propaganda that the government has completely supported. This has been a massive scam against the world, against the United States and against the world. These drugs work. There is no question scientifically. They are proven to work. And when used as in outpatients within the first 5 days or so of the infection, and they should never have been suppressed in the first place.
I'm just curious as to whether or not you've received any criticism or feedback from your peers in the scientific or medical community regarding your thoughts on vaccines. Clearly, this is an unpopular opinion by mainstream standards.
Well, you have the problem that the mainstream standards are controlled by mainstream media, which is controlled by massive financial interests that also have the same financial interests in the vaccines and expensive medications. So, and the same is true for medical research across universities, that a very large amount of clinical research in all universities in the United States, Canada, and Europe is supported by pharma company grants to those institutions. The allegiances across all of academic medicine are very large. Jason Fung, who's a physician in Toronto, pointed this out in 2017 in a video that's gone viral about the pharma interference in objective medical science, and this permeates the entire field. So one cannot rely on opinion in this. One has to go and look at the scientific studies and decide for oneself. As the philosopher of science Karl Popper in the 1950s stated, studies about what scientists believe are unrelated to studies about the way nature works. Nature works the way it works, and you have to go back to the scientific studies and read them and think about them, not rely on what people tell you they do, because the people have interests that are not necessarily the same as the scientific objectivity. So don't take my word for it. Read what I've written on in various places and go back and look at the original studies themselves and think about the original studies.
Okay. So just final thoughts. Booster shots, they're not, are they effective? Do we need them? Aren't they supposed to combat mutations?
Booster shots are effective starting about 2 weeks after the shot, lasting a month to 2 months after that, then they become non-effective. So the problem with booster shots is you have to give them every 6 weeks in order for people to stay protected and to reduce transmission. And that's a completely impractical solution and will damage their immune systems dramatically over time.
Okay, I understand. And finally, in the early days of the COVID-19 pandemic, we saw a complete failure of the healthcare system to respond adequately. Hospitals were overwhelmed, not just across the U.S., but across the world mostly. Was this largely unavoidable, or could we have avoided that disaster?
There's actually some discussion now about the nature of how much hospitals were overwhelmed. And I can't really speak to that. I don't have original data on that. Mm-hmm. However, there were probably some hospitals that were overwhelmed in New York City, for example, and maybe in Italy. But whether that was a general phenomenon across the world needs to be reevaluated with more objective information.
All right. Well, Dr. Risch, I appreciate your candor and your insights. Thank you for coming on the show.
Pleasure to be with you.
Thank you for watching Kitco News. I'm David Lin. Stay tuned for more.